Hello, and today I am joined by Dr. Chris McCarthy, who is clinical lead at the Faculty of Health and Education at Miles University, Manchester Metropolitan University. Chris, how you doing?
All right, nice to see you again, Andy.
Likewise. So where are you speaking from today?
So I'm in my office, which is in the what's called the Manchester Movement Unit, which is the clinical facility in the Brooks building, which is the where we house the Faculty of Health and Education. So it's a 6-bedded, essentially a physio clinic, but we do more than physio in here. But it's also attached to the movement laboratory of the faculty. So we've got a motion analysis set up there and a number of force plates and a split belt treadmill with force plates in it, and then all kinds of lovely data analysis toys. So it's a lovely, I'm very lucky. It's a very lovely facility to work in. But as I mentioned to you before the video started, I've got an infrared lamp on in the background because it's blinking freezing in here. We win awards for being the greenest university, and it's probably because we never turn the heating on. It's just freezing.
Yeah, no. I mean, it is an incredible facility, having been there several times. And so when you joined that, I'm skipping forward a bit to that now. Did you join when you were moving into this facility?
I came back to Manchester about 8 years ago, and the building had been open for a couple of years. The sort of backstory to this clinic actually was that there used to be a BSc in acupuncture that ran over in the Hathersage Road site before essentially the Didsbury campus was sold, and then they got some money to build the Brooks building. So in that particular course needed an on-site clinic, and so that's how the clinic first started. It started from an acupuncture clinic, and then it morphed into what now is predominantly a physio clinic, but we also do occupational health things here and sports nutrition and sports science and so on. So there's various different things that happen in here now. So essentially, yeah, the building opened with a pre-built clinic in it. It's got cameras and microphones in it, which are shut off at the moment, but it can be used as a sort of simulation suite as well. So you could be filming people doing physio in there without them, without being in the cubicle with them. So it's a lovely facility.
Yeah, no, it's really good. When I first moved to Manchester, I lived literally right near the Asda, so I know that.
Okay.
I know that area very well.
Yeah.
So no, it's good. It's a massive addition, I think, to the city. And like MMU or Manchester Metropolitan, that they seem to just spend an absolute fortune on infrastructure. Like, I mean, I live in Didsbury now, so I know the old campus and what that's been turned into very nice houses and apartments there.
Yes.
But like the university, they really have changed. They've been a massive part in changing Manchester's landscape.
Yes. Well, we're in Hume, so I was here 20 years ago, and you didn't go into Hume unless you really needed to, because it was a bit fiery at times. But it wasn't just this university, but the whole regeneration of Hume has been amazing. And we really do try and link with the community as best we can. So we offer discounts, for example, to the local community to come in and have treatment. And we're always trying to battle this slight barrier that there is when you stick a university building in a community. Is there's that feeling that it's just for students and not for the community. So we have quite a lot of community events and things to just bring the community into the building. So it's seen as being sort of integral. If you're out there in the evenings, the number of folk out on roller skates and skateboards and so on, and the music's on, and it's it feels like it's sort of bedded itself in over time into Hume. So yeah, it's a good place to work.
Yeah, no, it's a diverse community around there, isn't it? Because we were right by like the kind of Moss Side leisure club.
Yes.
And yeah, I remember reading the books on, all the things that had gone on not that long previous, because I think I was about 20 years ago I moved there. So yeah, no, it's a really, but I love Manchester in general. I think it's a great city, and it's really developed over time.
Yeah. Well, when I got the chance to come back about 8 years ago, I jumped at it. I was here, gosh, in the early 2000s when I was doing my PhD. So the School of Physio in those days was at the University of Manchester, and then it moved to universities. Well, I went off to Warwick and then down to Imperial, and came back, and it swapped over gone over the street to Manchester Met. But yeah, I love Manchester, absolutely.
And it's, I mean, because I was at the Crewe and Alsager campus, and like even that was they've lost a lot of that now, and it's all been centralised
Oh yeah.
into Manchester. I know
Yeah.
this is not directly to do with you, but I'm for me interested from my own side. How do those decisions get made? And like, it must be a massive operation,
Oh, it was
moving,
huge.
selling land, buying land.
Yes. I mean, ultimately, Andy, as you can imagine, that just financially it wasn't working having the campus down in Crewe. Doing brilliant work down there and fantastic facilities, as you know. You were there, amazing facilities, but it was just the university couldn't make it work financially, and it was better to centralise things. And so initially, then everything moved up to Platt Lane, which again, I know, which used to be Man City's, old training ground before they got rich. And then of course the Institute of Sports opened a couple of years ago now, so they've all moved into there. So, and it's really useful now that we've got these closer links. So you've got the Faculty of Health and then the Institute of Sport, right next to each other. So it's really helped with collaboration there. So it's good.
Yeah, no, it's good. It's a really exciting time. As I was saying before, like caught up with Warren Gregson over when I was at Isokinetic in Madrid, and the collaborations with some of the local teams that are around here. It's really good to see that there's different working relationships with, Man United and that sort of thing as well.
Yes.
So it's exciting. It is exciting times.
Yeah.
So yeah, in terms of you then, like for your like getting involved in this area, how did you? I know you said you were in Manchester before, but like where did you grow up, and how did you? What prompted you to want to move into this world?
Well, I started thinking about this when you said, "Oh, do you want to do this podcast?" I thought, "Oh, right, okay." And then you said, "Right." Well, I said, "What do you want me to talk about?" And he said, "Well, there's no prep. It's just talking about you." And I thought, "Oh God, I better have a think about me then." So I had a little think. And if I really think back about, when did I first think about physio? I think it was about 15. So I just had not chosen biology O level as it was. I thought there's a lot of back pain around, isn't there? There seems to be a lot of back pain about here. I bet you there's a lot of work to be had in back pain, and I'm going to go into that field. So at age 15, I thought that's where I'm going to go. So then I had to do A-level biology without the O-level biology because I hadn't chosen that option, and then straight into physio. So that's 40 years ago, Andy. I'm 55, so 40 years I've been learning to do physio or doing physio. And
It's very
predominantly,
mature that though. If like so at 15 you saw a business opportunity then. Was it a business opportunity or were you
I
looking to
think it
help
was
people?
something like that. It must have been some kind of, right, what can I do where there's lots of work? One of those kind of insecurity things, perhaps. And back pain was what I picked on. And my God, it was a good choice, Andy. It's a global, it's the most costly condition, globally. When you look at the costs of back pain in terms of the amount of disability it causes, particularly in the working age group. So, being interested in back pain has served me well as a career, really. So, I went to Coventry Uni to study physio in '86. And in those days, there was only a couple of places where you could go to uni to do physio. In those days, it was most schools of physio were attached to large teaching hospitals and weren't degree courses actually. So there was Coventry and Mile End, I think, in East London. So I went to Coventry for 3 years, and then I read something about the Northwest Regional Training Program for junior physios in Liverpool. So I went to Liverpool as my first job, just after the Hillsborough disaster, actually. So I got involved in some of the rehab for some of the people who'd been involved in that. And that started my passion for Liverpool Football Club from 1990. So started supporting them in 1990, and then they didn't win the league for 30 years. It was like this albatross around their neck. But yeah, I worked at the Royal in Liverpool for a few years on rotation, and then actually locumed fairly early to get some more musculoskeletal experience, and then got a training post at Wiston. There was some expert physios really in the musculoskeletal world who had a training post at Wiston Hospital in Wiston and St Helens, and got involved in a group called the MACP, what is now called the Musculoskeletal Association of Chartered Physios, mainly because they just seemed to know what they were doing. They seem to be pretty expert at what they were doing. And then that's been my passion really for the last, I don't know, 35 years is this group, the Musculoskeletal Association, is about developing expertise in musculoskeletal practice. And it's been a brilliant thing to be involved in. I've been the chair of it twice and been on the committee in various different roles. And it's just a great model of CPD for people interested in musculoskeletal work. It just drags you into doing things you wouldn't do otherwise, and meeting people you wouldn't do, and international conferences and organising this and that. And really, really useful thing to be involved in. So
yeah, for that then, so that's it's that title, it's a respected organisation and so on. So when was that formed, and like what is how many events are run with that?
Yeah, so the MACP is the same age as me, so it's 55. It was set up by some sort of very famous manual therapists back in the day. And it was one of the first groups that joined an international group called IFOMT, the International Federation of Orthopedic Manipulative Physical Therapists. Usual story, great big name. And there's a big conference, big IFOMT conference this year in Basel in Switzerland, which happens every 4 years. So yeah, it's been around 50 odd years, and it's, I guess it has its detractors and it has its fans. Obviously, I'm a big fan. It has its detractors because there's a perception that it's elitist, that because it's about developing expertise, that there's some kind of elitism involved in it. But in my, from my point of view, it's not elitist at all. Anybody can join the MACP. There's no sort of selection process based on you or how you look or whatever. You just, you undertake the courses, pass the exams, and you're in. It's about, for me, raising the bar of clinical reasoning and expertise. So it's a really useful organisation, and it's been morphed into developing about 10 or 12 master's programs that are set in various different universities around the country, including our own. And if people are MACP, it's really a sort of international kite mark, like a standard setting kind of thing, that this person has reached another level of clinical understanding. It's a kite mark you can kind of trust that this person's done a decent bit of postgraduate education. So some real value in it, Andy, I think, in terms of, you see it in the sports world all the time. There are various different tiers, levels of expertise that people go through when they go through the sort of the sports training sort of programs that are in the various different groups. And the MACP is just another one of those models. But, it's really, I'd recommend it to anybody really in terms of developing their expertise.
And how did you get involved in that?
Well, again, when I went to Liverpool because there was this training program that they offered. So you got a little bit of training on cardiopulmonary stuff and, pediatrics and then musculoskeletal. And the people who were teaching the musculoskeletal sessions were all MACP members, and they just seemed to know what they were talking about. They were standout, really good clinicians. So it inspired me to follow them really. And of course, things have changed a lot. When I think about it, Andy, I went through a 3-year training program, 86 to 89. And I think we must have mentioned evidence-based practice maybe once in the last term. In those days, you didn't read meta-analysis of the evidence. There were no meta-analyses of the evidence, in physio. You read the textbooks and you listened to the experts, and that was how it went, in the late 80s. And it was only after that once I'd qualified and you get into a master's program that you realize, oh my God, there's a host of evidence out here that I just wasn't aware of. And so then, my approach to practice changed with that. And the MACP's approach to what it's done over the years in terms of training has drastically changed from what I was taught in the early 90s to what's being taught now, which is incredibly evidence-based, and incredibly, I think, non-biased and critical of the evidence. We're it's growing up. The association is growing up as the evidence base is growing up. It's.
Yeah, and how do you get the balance between you being able to get research but having it applied so that it can be useful in clinical practice?
That's probably the most difficult thing, I think, Andy, you know, because when you look at the quality of the evidence that's out there, you know, we're not providers of medication, so we're not undertaking massive randomized controlled trials, you know, with health economy analyses. So when you look at a lot of the evidence for what we do in the exercise field and in the manual therapy field and in the electrotherapy field, it's all really quite low level quality evidence because it's not big enough, you know, and it's not been repeated enough, and there isn't a health economy analysis attached to it because the finances you need, as you know, for running a massive clinical trial are absolutely huge. You know, I before I left, I went to Warwick a few years, skipping back a bit now, but a few years ago, I used to work at Warwick Medical School in the clinical trials unit there. So we're talking over, let's say 15 years ago, and I got funding for a clinical trial looking at strengthening in rheumatoid arthritis of the hand. So a simple trial comparing different types of exercise for rheumatoid arthritis in the hand with a health economy analysis done properly was over £1 million, and that was 15 years ago. You know, it's astounding how much money, the funding that you require to do a decent, you know, high quality, adequately powered randomized controlled trial. And that's just not there in physio. So the quality of the evidence is so difficult, you know, to really sort of bring in. But it's a really, you know, answering that question is really difficult, Andy, because the quality of the evidence isn't there, or it just isn't there at all. And then you're left with your views and the stakeholders' views, you know, and so it's that balancing act between, you know, what evidence there is and what's appropriate for that individual at the time. So that's almost the art of it, really.
Yeah, no, it is a really interesting thing from our side, from industry. There's a lot of the time you can tell certain people it's like, right, what's the evidence? But they don't really want the evidence, but they maybe want something to prove that your thing doesn't work.
Yes. Yeah.
And it's like, I think you're trying to get the balance right, because obviously you do need something that's safe and has got some justification as to why it's used.
Yes.
But it is an art as well as a science.
Oh yeah, absolutely. I mean, it's, you know, I don't want to make that sound like I'm suggesting that, you know, evidence isn't the most important part of that triumvirate. You know, it is. You know, we've got to get the evidence. You know, we've got to use that as much as we can. You know, it's not just about my views and the stakeholders' views. We've got to be guided by the evidence, but we have to accept that at the moment the quality of the evidence at times is not strong enough to be confident that you're necessarily, you know, doing the right thing.
Yeah, and what led you? So you've been at Liverpool. What did you have as your pathway? You already identified that you thought back pain was an opportunity.
Yes.
What did you do after Liverpool? And what did you have a clear path of what you thought you wanted to do?
Yes, well, I wanted to join the MACP, so then that was the first port of call. So then Coventry then ran a masters. It was the first masters in to allow you to join the MACP in Europe, actually. So I went back to Coventry again, second time. You know, once wasn't enough, and started the masters program there. And then I was really lucky, Andy. I mean, sort of, you know, my career has been a bit like this. Things have just fallen into my lap. But I was just about to finish that, and there was an advertisement for a post to run a clinical trial in exercise and knee osteoarthritis at the University of Manchester, during which time then you could do your PhD. Now, these things don't happen very often now, you know, and if we're talking about 1998, you know, you never saw this ever. So Pauline Mills, who was a lecturer in the school here, and then Professor Jackie Oldham, who was then my mentor for a number of years, were advertising this post, and I managed to get the post. So then I moved into research so I was about 9 years qualified, and then went into the research field then. And we did a big trial looking at the joys of class-based exercise versus individualized exercise for knee osteoarthritis, on which I was able to tack up some PhD work, which again I think is useful. I think if people are watching this and they're thinking about doing research, you know, very often I get queries from people I want to do my PhD on this particular topic. And you can tell this particular topic is their passion in life. You know, they want to show that this does this. And, you know, they want to show that this does this. And, you know, they want to show that this does this. And, you know, they want to show that this does this. And, you know, they want to show that this does this. And, you know, they want to show that this does this. And, you know, they want to show that this does this. And, you know, they want to show that this does this. And, you know, they want to show that this does this. And, you know, they want to show that this does this. And, you know, they want to show that this does this. And, you know, they want to show that this does this. And, you know, they want to show that this does this. And, you know, they want to show that this does this. And, you know, they want to show that this does this. And, you know, they want to show that this does this. And, you know, they want to show that this does this. And, you know, they want to show that this does this. And, you know, they want to show that this does this. And, you know, they want to show that this does this. And, you know, they want to show that this does this. And, you know, they want to show that this does this. And, you know, they want to show that this does this. And, you know, they want to sho and they want to do it with a PhD. And so they want to get into that particular thing with the passion associated with it. And I'm just, it's nice to see, I think, that actually you can do a PhD in something you're not particularly passionate about. Osteoarthritis and exercise, knee arthritis and exercise isn't my passion. But doing a PhD in it is a massive learning curve. The process of doing a PhD is a huge learning experience. So it doesn't really matter so much what the actual topic is. And I think sometimes actually doing a PhD in something that you're fairly equivocal about means that there isn't that element of bias that you can hear in some people's presentations in conferences. When people start their presentation with, this is my PhD work, I think, oh, hello. Let's just see. Let's just see how biased this is. This was the thing I went into. I went into this because I had a passionate view about something, and I did a PhD on it to prove this. And I think, really, our standpoint's got to be, neutral. And then you just go with the data. You go with the evidence. So, so I did a PhD on something that I wasn't, not my thing. But the joys of having the PhD then is as you know, it opens the doors then for postdoc fellowships, which was on back pain, and then opens connections and opportunities come your way once you've sort of met that sort of benchmark of getting the PhD.
And what skills do you need then to be a good researcher, having come from clinical practice?
Yeah. Well, I think there's a need to accept that there's bias in everything we do, and that you have to take every opportunity to reduce that bias. Could this be replicated by somebody else who isn't me? That was the thing I had to keep coming back to all the time, because it's so easy when it's your thing and you've got a certain amount of time to do it, and there's all this kind of demand on getting papers out and so on, that you just think, oh, okay, well, I'm just going to cut a few corners here. And it's stopping that and being rigorous, having standard operating procedures and being as rigorous as you can, so that somebody else could come in and do what you're doing, without the personality involved, and get the same results. I think that's the key thing I got from the whole thing, is just making it step by step, absolutely, repeatable, so that you're confident at the end of it that that's as unbiased as I could get it. The only difference between these groups is down to that variable and nothing to do with Chris McCarthy. It's that approach, I think, is what I really learned the most.
I can imagine it is quite tricky though, because it's like you hear all of these things out there, be passionate about what you're doing. We were talking before about doing things that you enjoy doing. So how many PhDs, and this is, I don't know if you'll have an answer to this one, but how many PhDs do you think are done as a passion project, and how many are done because they want to do a PhD and they want to go through that process?
I would think the majority are the former. I think most people, as you say, when you go into this, it's an absolute sod in terms of your life. It takes over, and I always try to recommend people don't do a part-time one, because you've got 6 years of it being a sod as opposed to 3 years, of it being a sod. It's just your life gets consumed by this thing. So, it's therefore the motivation does tend to be, I have a particular passion in a certain area. But then more and more now, you're seeing some of the newly qualified graduates, who have got a couple of years of experience, want to get back into academia, and they can see that they need the PhD there in terms of their research career. So there's a new cohort, I think, coming through, who are passionate about the process of that level of degree rather than necessarily the topic. But I think you're right, Andy. The majority probably are still, this is my passion, and therefore I'm going to explore it. Having said that, Andy, I do say to all my undergrads who come through here, we've always got undergraduates in. Start thinking now about what you want to be the world's expert in. What do you want to be the thing that you are so good at and so well published in, that you're invited to conferences in Rio de Janeiro and Hong Kong and places like that? Because the people who get through, the graduates who get through, they're bright folk. They're passionate about the evidence base, and why can't these people be the stars of the future? So it is a real balancing act between bias and actually chasing a dream.
Yeah, no, and I think it is. I reflect on to me and mine is like, do I question it a lot? Is that, am I passionate about shockwave? Am I passionate about diagnostic
Mm.
ultrasound? And realistically, no, I'm not about those technologies. It's about what does that impact have on the
Mm.
clinical expertise or helping people, whether it's probably not even people's, like one of my team is like, oh yeah, I want to help the patients. That's probably
Mm.
not a driver for me. It's how do I help the clinicians or the businesses of those
Yes.
people, or that's really what mine is. So you can have your own interpretation and passion for in it, but doing the same thing but in a different way. And I think that's trying to, it's not the same. You can be doing the same thing but have a very different motivation for why you're doing it.
Yes. Yeah. Well, the one of the things I think that you may come across, I'm certainly seeing, is that there just seems to be a bit of an issue, certainly within the NHS. So bear in mind, 8 years ago, I was a consultant physio in the NHS at Imperial in London. So had a nice, again, lovely role where I was half the time in the orthopedic clinic doing the spinal team's work in an orthopedic setting, and then half the time leading the spinal physio team within the physio team. So it was a lovely mixture of sort of what used to be called extended scope of practice, and physio. And in those days, I mean, we're talking 8 years ago, people would come in and what I would consider to be treated by the physio. There'd be some change in symptoms associated with some kind of education or exercise or manual therapy, and then they'd leave. And then they might be seen the next week to check that we're doing the things at home that mimic the treatment effect in the clinic. You know, that in my mind is sort of an interventional kind of physio session. More and more, it seems that people go and see a physio now in the NHS, and because the demand on the physio's time is so high in terms of getting new patients in their diary, they can't see the patient for 6 weeks or something. So basically, people are going along, seeing a physio in the primary care setting or secondary care setting, being given a sheet of exercises and told, right, well, I'll see you in 6 weeks and see how you're getting on. So there doesn't seem to be a lot of, I mean, obviously that's an intervention, but there isn't much intervention in the session, you know, with something like shockwave or something like laser or, you know, some of the things that you're interested in and that we have in the clinic here. So when we have undergraduates who've been to the NHS on placement, they look a little bit surprised at times that we're actually doing something to the patient in the session, you know, and that's a worry for me in terms of us losing that the power, the educational power of changing symptoms in a session. You know, if somebody comes in and I'm going off onto one of my little bugbears, Andy, I hope this is all right, but it just drives me mad when people come in and they've got their MRI scan with them, as is the way these days. They've stopped being them and they've become the report. You know, they've become an L45 disc prolapse and they've got the disc there. And you change their symptoms so they've got half the pain they had when they walked in by doing some kind of exercise or manual therapy or something. But then put the message on that, well, look, your scan's the same as it was when you walked in, and yet you've got half the pain you had when you walked in. So this problem isn't about the disc, it's about how your nervous system is dealing with the threat associated with it and your muscle spasm and so on. That message is so powerful for people that if we lose the ability to change people's symptoms in a session with physio, we're losing that message, more importantly, I think, and people just aren't getting that benefit of being shown that their biomedical features, you know, the scan report or the ultrasound scan, is only one aspect of them. And the most important bit is the three-dimensional moving part of them, which we can change in physio. So, you know, it drives me mad that we're sort of leaving that, letting go of that, you know, whereas we ought to really be hanging on to that as a method of educating people. It's just physical education. Manual therapy for me is just physical education, and we're going to lose it if we're not careful.
Yeah. And so how is that going to get done?
Well, nobody's going to listen to me. I know that. So I'm hoping that the new generation that come through here and come through various physio schools where they do encourage that manual therapy and education is just part of a part of an educational process for the patient. You know, if that message comes through with the next generation, then we'll be okay. But if the new generation of physios gets drummed into the idea that you don't need to see people more than once every 6 weeks, and you only need to give them some exercise sheets that they could actually have got off Google or YouTube, then physio is going to be in trouble, really, because there are other professions out there who are much more, let's call it interventional, than that, and the market will shift away from physiotherapy to sports therapists or others. We've got to watch this, otherwise we're going to get left behind.
Yeah, no, I think it is an interesting time on it with AI coming in, and it's amazing to see what the things we can do now even.
Yeah. I was on the NICE committee looking at technology, the early adoption kind of technologies for back pain recently, looking at some of the offerings that are looking to go into the NHS. And as you say, some of the AI offerings now are really starting to offer algorithms that do offer something different than just, it's a digital technology because it's a Zoom call with somebody or a Teams meeting with someone. There are opportunities now with AI, I think, that can really help. and as you say, in light of that, then physio really needs to keep up with that.
Now, how do physio courses, how do they keep up with those things? Because I can imagine there's a very established syllabus of things that they go through, and I know some of the technologies that aren't essential now but are widely used.
Yes.
And then how does it keep up with that? And then AI coming in, which you need to embrace this stuff, I would have thought, rather than saying, oh yeah, that's rubbish.
Yeah, exactly. No, I think you're right. And funny enough, I was talking to somebody here yesterday about setting up a clinical network of clinicians in Manchester to almost be a stakeholder group for the development of the next undergraduate programme, so that really the university is offering clinicians what they want to see from the students. Sometimes there's a discord or a mismatch between what the tutors on the program think is important and what the actual clinicians on the shop floor want. So I think we need better communication between those doing and those teaching, really. Jobs like mine, I mean, the role I've got, I'm blessed because it's an absolute mix of the two. It is clinical practice, and I'm working with some brilliant clinicians. I mean, we've got Tom Hughes, who's come from Man United, in here now, and we've got an intern who's a sports physio called Will James, who's excellent, and then Ben Digweed, who's just been off with the GB team to the Winter Olympics. So we've got some amazing clinicians in here, and that gets fed back through into the programs. But it's like all schools of physio and other health professions. If there's a big disconnect between the tutors and clinical practice, then of course it immediately starts going out of date. So we've got to keep our fingers in the pie of clinical practice, otherwise, the course won't match what people need in the real world.
Yeah, no, I think it is good you've got those people that they're young guys as well, aren't they? They're like they've got good experience and so on, and they're really passionate about what they're doing as well.
Yes, well, that's right, and it's been an eye-opener for me, Andy, because my career has been in the NHS, and really late stage rehab in the NHS has never been particularly linked. You get so far on the NHS, and then the demands on your time are such that people are left to their own devices for the late stage side of things. And then you see what these guys who've worked in sport all their careers are like. It's a different level of expertise. It's been really good for me, to see the level of expertise these clinicians have in exercise prescription and adaptation to particular pathologies. It's clever stuff.
No, it is. And how do you see it? Because you see in the NHS, we're getting into not much about you here now, but your opinion on things. But it's
I'm just soapboxing here. Sorry.
No, I like it. They're all genuine questions for me. So it's like the NHS. When I first moved into the area of working with tech and so on, 70 to 80% of my time was spent with the NHS, and we'd be selling equipment there, supporting that area. Whereas now we've really moved away from that, and we're working with sports teams, still doing some stuff with the NHS. I was in there yesterday, but it's really the private clinicians we can see, because MSK is, the demands on the NHS is quite extreme.
Yeah.
The big opportunities. So we're spending a lot more time there because, well, frankly, they're spending the money more quickly than the NHS are. So how is the course how does the course cope with that? How does it train people? How does it adapt with that changing landscape?
I think the short answer is slowly, Andy. I think what I'm seeing is the discrepancy between what's being taught. And I don't just mean our graduates. I mean, I have more than we don't just have MMU graduates here, but when you get out into clinical practice, you see there is just, there's a steep learning curve when people qualify in terms of what they've been taught and then what they're expected to do. So I think, as I say, I think the only way I can see that improving is that you have much more connection with the clinicians, so that there's a real tailoring of, look, this is exactly what we want from your graduates. So let's provide it, in light of the fact that, we can't do what we used to do because we haven't got the time or we haven't got the equipment, and, the demands are different. First contact practitioner posts now are becoming, the goal for a lot of our postgrads. So we have a huge international cohort of students who come here, and the vast majority of them want to become first contact practitioners. So they're learning very detailed examination procedures in the musculoskeletal world, which they're going to take into a sort of triaging role. So the first contact practitioner, as is the person now who, if you have a musculoskeletal thing and you ring up your GP practice, you'll get diverted to a first contact practitioner physio rather than the GP. So it means that these roles are much more medical in their kind of training, and it's very, very sort of diagnostic and pathway pointing. But it means there's much less physio done by these practitioners. In fact, some of the time they don't do any physio. There's no time aside to do some physiotherapy treatment with someone. It's a question of, right, well, I'll send you to physio. So we are, again, unfortunately, I'm seeing that a lot of the senior members of staff in physio departments are becoming first contact practitioners, and then they disappear off into primary care doing the work with GPs, and you could say instead of GPs or for GPs. And then physio departments then have a dearth of senior staff who know how to rehab complex patients because they're all out doing FCP work in the primary care. So the face of MSK practice is shifting so much. I mean, we're lucky that we've got really good people in Health Education England, physios involved in this. And, from a national perspective, things are changing, and there's various different pathways that are being incorporated and written by physios. Andrew Bennett used to be the lead of musculoskeletal in the UK. I think he's changed roles just recently, but he is an MACP member. But there's a physio there, developing pathways for MSK nationally. So, we're in good hands. I mean, I don't want to sound too kind of old and skeptical and so on, but I'm just aware that, if we're not careful, we're not going to keep in tune with what's actually going on in the NHS practice.
Yeah, no, it's an interesting time, and things do evolve and things progress, and ultimately, I'm sure it all kind of works itself out. But it does certainly from my side, it feels like there's quite a big shift of clinicians going straight into private practice, and
yes.
The FCP roles, all of that. It feels like there's quite a change in the last more recent few years.
Oh yes, yeah. Well, I was doing what is now called FCP, but back in the day it was called Extended Scope of Practice, ESP work. In 1993, 1994, we had a little trial in Halton General Hospital in Halton, Runcorn, where we had a physio in an orthopaedic clinic, doing some of the orthopaedic work there. And it was all, when you look at where this country is in comparison to, say, Australia, Australia is way ahead of us in certain aspects of practice. But when it comes to first contact practitioner work, from a legislative point of view, we're quite a long way ahead. And it's come from the waiting list issues. The reason that physios were developed for these roles was really to get the waiting lists down. And that's still going on now. We're still trying to tackle the orthopaedic and surgical and medical waiting lists, which is great. But, at the same time, physiotherapy waiting lists are going up. So we've got to get the balance. Right.
Yeah, but you see the same the changes in elite sport now, where there's so many massive medical teams, and yet injuries are going up still. So there's challenges in each different area
Yes.
that you've
Yeah.
got.
Yeah.
Yeah, and in terms of like for you then, so you've been involved in publishing. I know that's part of your role. You've written a book as well. So like, how do you find doing that aspect of your work?
Well, it's I'm blessed, Andy, because I've got this role where I'm clinical and I do some teaching on the postgrad program, and then have some time to do some research. So, if I was designing my own dream job, and we were talking beforehand about, what percentage of your job do you need to be, happy with to have a dream job? I couldn't really ask for more. I'm really blessed. But then saying that, of course, trying to squeeze in when you've got lots of components to the job, trying to squeeze it all in like your job, it's tricky. So, I'm lucky. I've published a book in 2010 on a method of treating back pain, which if you've ever published a book, is not an earner. You don't. It's not something that makes you any money. But what it does is people become aware of you or the ideas that you're talking about, and then you get invited to do courses around the place, and then I find you've really learned, because you're off internationally meeting people and seeing how people do things in different countries. And for me, that was the big leap in my practice, was just seeing how people do it outside of the UK. It's so useful if you go and teach a course somewhere and just find out how things work and how they approach things in a different part of the world. So that's been useful. And then, yeah, I've published a few papers over the years and a few chapters on this, that, and the other. And the thing I'm most proud of is there's a book called Greaves' Modern Musculoskeletal Physiotherapy, and Greg Grieve was one of the founders of the MACP, and in fact one of the founders of IFOMT, which was that big international group I mentioned at the beginning. A really sort of legendary physio, miles ahead of his time in terms of evidence-based practice in the 1980s. And he published a book which I'm one of the editors of. So the 4th edition came out in 2015. The 5th edition is coming out next month. Actually the month after, so August. And it's a brilliant, if you're doing I'm not trying to advertise it, although it does sound like that, but if you're doing a master's, it's the book to get. There's 60 chapters, all the big hitters are in there in terms of how to do musculoskeletal physiotherapy, and being involved in that with some of the other editors, so Jeremy Lewis and Deborah Fowler and Chad Cook and Michelle Sterling, and these people are, they're real high level academics, and just spending time with them, you see, actually, this is the next level for me. It's this kind of CPD, you could call it, that's been really fruitful for me, is working with real, high level academics and seeing how they do things. So, as I say, I'm blessed, Andy. I couldn't really have a better mix. Like all jobs, there are bits that, are a bit of a pain. But broadly, I've been blessed.
No, good. Glad to hear it. It's nice when people say it, and you can tell it's genuine. It's easy for people to say how much they love what they're doing, but like you say, there's challenges in everything that you're doing. And if it was all good, then it wouldn't be all good, would it? Because that would just be what the norm is anyway. So
yeah, exactly.
Yeah. So what would you suggest is like, what skills do you think you need to be a successful person? Not really on the clinical side, but within the roles that you've done. What do you think the key skills are?
I think the biggest skill that I've realized, I think, as I've got older, is the ability to pause. So that extends from, so I've got a timer on my phone that goes off every 15 minutes, like a little mindfulness bell. And for me, little pauses like that have been so helpful in terms of bringing my sympathetic nervous system down. So I hadn't realized for years that when I've just spent 15 minutes staring at the screen doing an email, my sympathetic nervous system's ramped up. And if I stop when that bell goes off and just have a little deep breath and think, oh, where am I here? And just bring it down again, I think, right, well, that'll last me a couple of hours. And then 15 minutes later, it goes off again, and I realise it's back up here again. But actually, just calming that down through the day has meant that I'm much less of a stressed person than I was 10 years ago. And then extending that pause into, right, I've just had an email from someone and it's got on my nerves a bit. Pausing before I respond and just putting it to one side and coming back to it later in the day or even the next day, again, has saved me so much grief. When I think about the number of times I used to just react to things, and I try and respond to things now, and the only way I can do that is to force these pauses in. So I think if there's one thing that has made me, I would like to think, a better person than I was maybe 10 years ago, is just the ability to just not react so much and just have a bit of a pause before I respond to things.
That's good. Yeah, I love getting little tips like that because it just helps reinforce it. And I think just having like that, I've got the Apple Watch and you do like a minute of deep breath, and it helps. Like it definitely does help.
It really does. Yeah.
Yeah.
I hadn't realised that, having looked into this a bit, when you focus on something, even if it's an email, your primitive brain thinks that's a threat. You know, we're supposed to be panoramic viewing, looking around the planes, you know, and then if we're focusing on something, our primitive reptilian brain thinks, oh, that's threatening. So our sympathetic nervous system starts to creep up, and with that goes muscle tone and heart rate and so on. So actually, just this idea of stopping, the 20-20-20 thing is another thing that I find quite useful. You stop every 20 minutes for 20 seconds and look 20 meters away into some kind of large landscape. Again, it's good for your eyes, it's good for your concentration, it's good for dropping your sympathetic activity. So it's those little things that I've found really helpful.
No, I think that's really good. I've not heard the 20-20-20 I've heard sort of the Pomodoro stuff and different things like that.
Similar thing. Yeah.
Yeah. No, it's interesting because there's a lot of these different ideas and books and skills and all of it, and a lot of it is very simple, isn't it? Meditation, mindfulness, being present, all of those things. And it's the more that everyone I speak to, I'm busy, there's so much stuff that you can be doing. We were talking about it before, and you slip into it and it's like, God, there's so much stuff that you can be doing, that I should be doing, that I need to do. And it's like, actually, do you need to do any of that? And it's trying to out breaking all that stuff down, because albeit there's a lot of people telling us this stuff now, there's also, that means there's a lot more stuff to read, and like, what's a new best practice? What's this? Whereas the most simple things are normally the best.
Yeah. We get a lot, you can imagine we're in the Faculty of Health and Education, so we get a lot of members of staff, faculty members coming for treatment. And I found over this 8 years that I've been here that one of the most important things I do with people before I get on and do some manual therapy, for example, or some exercise, is just put a hot pack on somebody for 10 minutes, 5 or 10 minutes, because they come down, their shoulders are up like this, you know, because they've just been battling with a load of emails. And you can't get to them, you know, you can't get past their sympathetic nervous system until you just give them a little bit of time to just, you know, to detune a bit, you know, just to let some of the tension go. Then you can get into recruiting muscles and loosening off stuff and so on. So yeah, I'm a big fan of the hot pack. I don't know if you sell them, Andy, but we probably need to get some more.
No, we don't do. But I mean, even that stuff is really interesting, because you see different technologies, and if it makes the client feel good, maybe it is warm, whatever it is, and you can have some science behind it and so on. But if it really works and they feel good after it, like with win-back technology, like I know the guys, and it's done really well. It's like, you just know that sometimes the tech-off therapy, people just like having it feels lovely. Does feel really nice on there as well. And it's where all that stuff sits in the grand scheme of everything. Like, I've got a question for you about laser, because like, we're approached all the time by companies. Do you want to sell this product? We've got this new most powerful laser, class 1, 2, 3, 4, whatever it may be.
Right. Yeah.
And then you've got people that, as soon as you say laser, it's really polarizing, where in my experience, most people are like, oh yeah, that doesn't work or whatever. And it's like, well, what are your thoughts on it?
Well, we had a big discussion about it a few years ago before we bought one. We bought a Thor system, I'd actually been to Thor when I worked at St Mary's in Paddington. I lived in Chesham, which is where Thor are based, and I've been to see them and had a look at all their diodes and so on. And they do seem to, I have no connection with Thor at all, but they just seem to have really good, when you look at the quality of the outputs from their equipment, it does seem to be stronger than a lot of the others and much more reliable. But yeah, I did a lit review in order to put a business case together to get one, and it was convincing. If the problem's fairly superficial, regardless of what it is, the idea of stimulating the mitochondria into producing more ATP. My YouTube feed is full of anti-aging stuff and people lying in LED sunbeds and things, because the mitochondria, it's all about the mitochondria now, and so I think we're seeing more and more evidence that's convincing. I mean, of course, you go back to the thing we mentioned earlier, you look at some of the evidence in physio trials and it's not very good because of tiny studies, they're not outcomes properly. There's a whole host of issues with the quality of a lot of physiotherapy research. One of the advantages of electrotherapy research is that you can do, because you can't see the laser, it's not visible. You could do double-blind trials in laser therapy in the same way that you could for some of the other bits of electrotherapy. So there's scope there. If somebody wanted to do some, straightforward randomized control trial stuff in laser, there's good scope for it to be done. But there was certainly enough evidence, 4 or 5 years ago when we bought the piece of equipment to use it for some of the acute soft tissue injuries. When there's an inflammatory process already happening, the idea of sort of energizing the cells into being more actively anti-inflammatory is kind of seems sensible to me. It doesn't seem, just personally, it doesn't seem to, for me, do much for the really chronic stuff. When you've got a chronic tendinopathy, it doesn't seem to change anything. So I'd lean more towards the shockwave approach to provoking a healing response than using laser. But with the acute stuff, it seems to really give pain relief immediately. Pressure pain thresholds change after a few minutes of laser, no question.
Yeah, no, that's interesting. Another one that's quite controversial is ultrasound, as in therapeutic ultrasound. What are your thoughts on that?
Yeah. Well, again, when shockwave first came around, I used to go to trade shows and bother the people in the shockwave stand saying, well, what's the difference then, between shockwave sound energy and ultrasound sound energy in terms of what it's doing to the tissue? Presumably it's similar, but, now I know, and Dominic's been to talk to us, well. And I now understand the difference in the amount of power between the two modalities. But again, ultrasound, I've just done a review on the use of ultrasound in coccydynia, along with laser and shockwave. And it's, I hate seeing these reviews and actually producing these reviews, but it's like, well, there's a bit of a suggestion that it's useful in coccydynia, but the quality of the evidence is poor and there's only 2 studies in ultrasound. And, it's the usual story, Andy. It's people ask me all the time, patients, what's the evidence for this? And you just have to be honest. And well, it's a little bit of evidence, but it's not great quality. So, we're going to have to just try it and see.
Yeah, no, I think it's a good outlook on things. But no, Chris, really appreciate your time on this. I've actually asked you a lot of questions that have been on my mind, which I didn't know were on my mind, but so it's been very helpful for me. So thank you for answering it. And
I hope it wasn't too soapboxy, Andy. Just
not at all.
A nice chance to talk about some stuff in physio, but it's nice to talk to you, and look forward to seeing you again soon.
Very much so. Yeah, Chris, appreciate your time. Thank you very much.
All right, all the best.
Cheers.
See you.